Welcome, everyone. We'll get started in a few minutes.
Well, welcome everybody. I'm Ami Gambari, co-chair of the Innovation Group at University of Michigan. On behalf of the Innovation Academy and the Franklin Cardiovascular Institute, I have the great pleasure of introducing my colleague and friend, Dr. Jessica Golbus, who is assistant professor of medicine at the Cardiovascular Institute and University of Michigan School of Medicine. She received her medical degree from University of Michigan and completed a residency program at University of Pennsylvania. She completed her general and advanced heart failure training at University of Michigan, where we were co-fellows together for a while. She also received her master's through the University of Michigan School of Public Health. She is actively engaged in clinical practice in areas of heart failure, heart transplantation, and mechanical circulatory support. Her research is really focused on using digital health technology, smartwatches to improve delivery of care and optimizing treatments for patients with advanced heart failure. She is a past alumni of the FCBC Innovations Program in 2020 and is going to speak to us about innovations using digital health technologies in cardiovascular care. Welcome, Jessie.
Thank you. Thank you so much for inviting me here and for the very kind introduction. Let me just go ahead and share my slides here. Okay, great. Hopefully you can see that all right. I'm going to be talking today about some work that our group has been doing in using mobile health technologies for behavioral modification in patients with a range of different cardiovascular conditions. I really want to focus today on highlighting a novel intervention design, just-in-time adaptive interventions, and an associated experimental design, micro-randomized trials that our group has been leveraging to intervene on patients with cardiovascular disease, including those enrolled in cardiac rehabilitation, as well as patients with hypertension. So I'll dive deep into a couple of case examples. I have funding through the NIH, NSF, and PCORI. The work that I'm going to be talking about today has been funded through a number of institutional grants here, as well as through an American Heart Association strategically focused research network grant on health technologies and innovation. So again, as I said, over the time together, I'll start by just level setting, make sure everybody understands what mobile health technology it is. I think we all know that already, but what types of data we can collect, talk about micro-randomized trials, highlight how those have been applied in the Valentine and MyBP, My Life studies, and then talk a little bit more broadly about challenges and future directions in the field of mobile health. Okay, so what is mHealth Technologies? I think we all likely know what this is, but the World Health Organization defines mobile health technologies as the use of wireless technologies to support the achievement of health objectives. So this includes things like text messages, GPS, and use of wearable garments or accessories that can provide physiologic monitoring. Now, importantly, mobile health does not include telemedicine, which is a separate type of electronic health. Now, wearable devices are a subset of mobile health technologies, and these are externally applied devices that capture functional and/or physiologic data, often continuously, and are paired with a second device, such as a smartphone, which can be used to collect and/or transmit the data. So when we think of wearable devices, we most often think of smartwatches like our Apple Watch or our Fitbit. However, we do include a much broader range of devices, things like the wearable cardioverter defibrillator or life vest or the Oura Ring, as just a few other examples. Now, this becomes really important later when I think about and talk about just-in-time adaptive interventions, but it's important that we understand the types of data that wearable devices can collect. So we most often think of these devices as passively collecting data on things like heart rate or blood pressure. There can also be blood alcohol level collected through a transdermal alcohol monitor. But in addition to this passively collected data, wearables can collect data actively. And so that's typically through short mobile questionnaires termed ecological momentary assessments. These can capture things such as stress and anxiety, pain, or fatigue, which may be much more difficult to capture passively. Now, these actively and passively collected variables, they may be intrinsically informative, but they can also be aggregated as part of risk scores to inform health prediction. So as one example, in patients with opioid use disorders, a machine learning model was trained to predict heroin and cocaine cravings using GPS data and participant level demographics. So I wanted to turn now and talk about just-in-time adaptive interventions and micro-randomized trials. And I'll start first just at a high level with just-in-time adaptive interventions and start very high with how we pronounce it, which is JEDIs. JEDIs, for those of you who are not familiar, is typically an mHealth intervention delivered through the use of a mobile application and push notifications. And JEDIs were designed to deliver support to the right individual in the moment where they most need it. So the idea is that these interventions rely on passively sensed data and data actively collected through short mobile questionnaires to identify the optimal time to intervene. So this will be opportunities in which individuals are at risk, say for and those I highlighted with an opioid use disorder, perhaps an addiction, perhaps relapse, or opportunities to capture on motivation to improve health. JEDIs take advantage of response heterogeneity by individualizing intervention options to the specific and changing needs of individuals. So in the screenshot you'll see on the right-hand side of this slide, this is from a mobile application that Mike Dorsch designed, who I know many of you may know. And this was part of a clinical trial designed to reduce sodium intake and encourage selection of lower sodium food alternatives. So participants, when they were entering, say, a grocery store or a restaurant, would be offered possible low sodium alternatives to foods that they commonly order or purchase. So what then are micro-randomized trials? So micro-randomized trials are an experimental design to aid in constructing empirically based, just-in-time adaptive interventions through the serial randomization of participants to different types of interventions and or different levels of an intervention. So the idea around micro-randomized trials is that they can be used by researchers to decide whether to include a time-varying component in a multi-component intervention and in which context delivering the component of an intervention is most effective. And I'll show you in the next slide what I mean by that. But the idea of a micro-randomized trials is it's an optimization trial to help with the design of just-in-time adaptive interventions. So again, this micro-randomization refers to sequential randomized assignment of an individual to one or several components of an intervention throughout the course of a trial. And the unique aspect with which micro-randomized trials operate is that people can be randomized very frequently. The same individual can be randomized every hour or multiple times a day. So the wearable device will passively collect data such as current activity level or location to determine whether a participant is available to receive a mobile health intervention. If they're available, say they're not driving or not currently physically active, then they will be randomized with a preset probability to receive or not receive an intervention. That time point at which they're randomized, that's called the decision point. And that intervention is dictated by tailoring variables. So things such as the weather, the time of the day, baseline level of physical activity could be used to make sure that the individual receives the right intervention at the right moment. And then the success of that intervention or the decision to intervene or not intervene can be assessed through proximal outcomes. And the idea is that proximal outcomes are mediators of the long-term distal effect. So step count, for example, in a physical activity intervention could be a mediator of changes in functional capacity or weight loss that may be the desired distal outcome. And proximal outcomes assess the effect of your intervention or non-intervention. So you'll measure, for example, step count after a decision point when people are intervened on or when they're not intervened on. And it's that within-person contrasts that make micro-randomized trials so powerful. So they're statistically and temporally efficient and allow us to improve our understanding of causal effects. So hopefully that was a high enough level overview to give you some context now as we dive in deeply into two different case studies here in which we delivered a just-in-time adaptive intervention that incorporated micro-randomization. So the first example here is the Valentine study. So the Valentine study was a prospective randomized controlled trial designed to evaluate a just-in-time adaptive intervention to augment and extend the benefits of cardiac rehabilitation. The study integrated a mobile application with physiologic and contextual information from wearable devices. So we enrolled low and moderate risk patients and then randomized them to the control or intervention groups of the study. And importantly, both groups received a smartwatch that was compatible with their smartphone. So Android users received a Fitbit Versa 2 and iPhone users received an Apple Watch. And then we followed participants for the remotely assessed outcomes of 6-minute walk distance, step count, and quality of life. So as I mentioned, the core of the intervention was a just-in-time adaptive intervention consisting of contextually appropriate smartwatch notifications. And notifications were one of two types. The first type of notification was an activity notification. So these types of notifications were designed to promote low-level physical activity, and they were meant to be appropriate for the current environment and actionable in real time. So these were tailored on factors such as the weather, the time of the day of week, and phase of cardiac rehabilitation. The second type of notification were exercise notifications. So these notifications encouraged participants to plan their exercise for the next day and suggested new activities to increase their exercise repertoires. So on the left, you can see an example activity notification that would be appropriate for, say, a 64-year-old female on a sunny weekend day, 2 months after she started cardiac rehabilitation for a heart attack. So I talked before about how in a micro-randomized trial, you can measure the effects of your outcomes of your intervention through proximal outcomes. So for the activity messages, we looked at step count 60 minutes after a text message, after the decision to randomize, as measured by the smartwatch. And then for the exercise planning message, our proximal outcome was the subsequent day's exercise minutes. So in addition to receiving notifications, intervention arm participants also had access to a mobile study application, which was paired with their smartwatch. This allowed them to self-monitor their activity data, things such as step count or exercise minutes, and then allowed them to set and complete activity goals, which they could then adjust based on their performance. Between October 2020 and March 2022, 940 patients were screened for eligibility, Of these, 422 patients were eligible for study participation, and of whom 223 were ultimately randomized to the intervention or the control group of the study. And 220 of these were ultimately enrolled. So using this completely virtual strategy of no in-person contact, we were able to successfully enroll 13 participants a month. And I'm happy if I'm not going to get into our pipeline for enrolling patients into these remote strategies today, but I think that that's something that could be a talk in and of itself. And I'm happy to talk on the side with anybody who has an interest in how we approach that. So this is our study population. So 38% of participants were greater than 65, approximately a third were female. We enrolled from both the University of Michigan and from Spectrum Health, with approximately 80% of participants being from Michigan Medicine. And about 2/3 of participants were enrolled and participated with an iPhone and an Apple Watch. And importantly, there were no significant differences between the two groups, the intervention and the control group, with respect to any of the baseline characteristics. So we had outstanding compliance within our study. Participants wore their watches for a median of 180 days, and 88% of participants wore their watches at least 75% of study days. And here, demonstrating the power of these micro-randomized trials, participants were randomized almost 71,000 times to receive or not receive an activity text message. And on average, this led to about one activity text message per day, which is what we were targeting. So displayed here are the primary results of the study. So this is the primary results of the randomized controlled trial, although I'll show you in the next slide the micro-randomized trial results, which I think are actually the more interesting. But just to orient you here to what you're looking at, so on the left, you'll see our primary outcome, which was 6-minute walk distance. And on the panel on the left-hand side here, that's with respect to Apple Watch users. Fitbit users are on the right, and we have our control group here in this orangey color and the intervention group in teal. So in univariate regression analyses, mean change in 6-minute walk distance for the intervention group as compared to the control group was not significantly different between the two groups at 6 months. We did, however, conduct an exploratory analysis in which we adjusted for baseline characteristics consistent with recommendations from the FDA. And while these results were relatively unchanged overall, they suggested possible improvements in 6-minute walk distance in Apple Watch users with a p-value that was just over 0.05. At 3 months, importantly, in a univariate analysis, we did find that mean change in 6-minute walk distance was significantly greater for Fitbit users in the intervention group, so suggesting possible near-term effects of our intervention. Now, turning to step count here on the right-hand side, again, Apple Watch here and Fitbit on the right, and intervention in group here in teal. And we did not have any significant differences in step counts at any of the time points between the intervention and control group. So turning now to the results of the micro-randomized text messages, which I think are the most interesting results from this study. So we looked a priori at 3 different phases of the study, which corresponded to phases in cardiac rehabilitation. So we refer to these as the initiation period, which was the first 30 days of the study and corresponded with enrollment in cardiac rehabilitation. The maintenance period, which was months 2 through 4, and then the completion period, which was the period following graduation from cardiac rehabilitation. And you'll see in the blue here, these are Apple Watch users, and then in the yellow are our Fitbit users. So amongst Apple Watch users, again in blue, during the initiation period of the study, delivering a text message increased 60-minute post-randomization step count by a non-significant 10%. Messages did not significantly impact step count during the maintenance phase of the study, although they did significantly increase 60-minute post-randomization step count by 6% during the completion phase of the study, again, the period after graduation from cardiac rehab. Amongst Fitbit users during the initiation period of the study, delivering a text message increased 60-minute post-randomization step count by an impressive 17%. Although this effect diminished over time, and we didn't see any significant impact of 60-minute step count during the maintenance or completion phases of the study. So in addition to the results that you see here, we are doing a series of moderator analyses in which we were trying to understand both the person and message level characteristics, which are leading to the observed effects. So we're looking at traditional factors such as age, race, and gender, but we're also looking at things such as whether the notification was personalized with the participant's name, what time of day the notification was sent at, the weather, and factors similar to that to help us better understand and, again, construct in the future these optimal just-in-time interventions. We're also trying to understand the effect of our intervention through participant interviews. And so we're coming at this from multiple different methodologic approaches. So this was work that was recently published in JAHA and was led by one of our internal medicine residents here, Namratha Lurie. And Namratha spoke with 17 Valentine participants in the intervention group to try and understand their experiences as part of the study and specifically interacting with those notifications. So participants in these interviews generally matched the larger study population. They were on average 65 years of age, about a third were female. They were evenly split between Apple Watch and Fitbit users and were predominantly of high functional capacity. Now, Namratha identified a number of important themes as she spoke with our Valentine participants. And I'm not going to go in detail into all of these here today, but I'll just highlight a few of them and provide a few illustrative quotes. And then I'll refer you to her article for kind of the rest of our lessons learned here. But the first lesson that Namratha identified was around engagement. So participants engaged with 4 main features of the mHealth intervention. So this was activity tracking, tailored text messages, goal setting, and weekly email summaries. And overall, we learned that at least qualitatively, participants preferred the activity messages, those that were meant to be actionable in real time. And while a subset did prefer exercise planning messages, most people, again, were interested in these activity text messages. So here's a quote here. The ones telling me to, if you have a few minutes to get up and do whatever set exercise from that message, those were the ones that I liked the most because they were really quick and it was something that I could do pretty much at any time. Now, certainly I would love to say that everybody uniformly loved our messages, although this wasn't necessarily the case. And I will say that people with higher functional capacity generally tended not to like these notifications. They found them too simplistic. So this one says, hey, name, hey, Jesse, why don't you stand up and touch your toes 5 times? I thought those were, adorable, but I didn't really ever take the prompts. So this participant felt that it was not appropriately tailored to his baseline level of functional capacity. And this was an important learning point for us. Now, Namratha also focused in on personalization. So she tried to look into how the mHealth intervention fit within participants' lives with respect to usability, applicability to their goals, and contextual appropriateness. So even those who had little experience with mHealth technology generally felt that the mobile application was easy to navigate and integrate into their lives. Now, participants generally wanted more personalization, and they felt that individually tailored messages were more likely to motivate action. So this was a woman with low functional capacity who said, if I set my goal with 10,000 steps and I did 5,500 steps, I would have preferred a message saying 5,500 steps, 4,500 more to meet your goal. I would have liked a more quantifiable message to meet my goal. The other thing that we learned is we explored how participants reacted to notifications that were inappropriately delivered. So, for example, telling somebody to walk outside when it may be raining. So something that was not contextually congruent. And for the most part, this really didn't bother participants. I think they appreciated what the text messages were designed to do, which was encourage them to find ways to be active in their current environment. So here's a quote to support that. Actually, I never looked at them that way. I took it as, hey, it's a good reminder not to necessarily go outside and walk around, but just to get up and move. And finally, Namratha's work really highlighted a number of important future directions for us that we are incorporating into our upcoming studies. So participants desired greater tailoring of text messages to their unique environments, as I said. And although participants acknowledged the trade-off with respect to potential invasion of their privacy, they felt it was an acceptable sacrifice to improve their health. So this was really an important learning point to us. We thought that security and concerns about invasion of privacy were going to be a major concern for participants, and that we were worried that if we tailor these messages to too great an extent, that would kind of deter people from participating. And that really seems not to be the case. So this quote highlights this. I joined the study because it was a way for me to be more accurate as far as measuring the outcome of what I was actually doing. And if I'm doing that and you're watching that part of it, I really don't see how I could have an objection to seeing what I'm doing in real time. The other learning point for us was that we really didn't have a way to incorporate social support into our intervention. So some participants really wanted to see that sense of community that they felt in cardiac rehabilitation embedded within the mobile intervention. And they desired kind of some friendly competition that they had felt that they were able to achieve when they were in cardiac rehabilitation. And they wanted to see that competition or gamification within the mobile application. So this one says, like in my case, I had a few people that I actually associated with at rehab. If you could connect to a bigger group of people to see how other people were doing, I think that would have probably made us a lot better than we were. So those were some of the learnings for us from the Valentine study. And again, we're still continuing to learn and adapt based on ongoing analyses and specifically work focused on those subgroup and moderator analyses. Now, I'd like to turn and talk briefly now about the MyBP, My Life study. And I say only briefly because this study is still underway and the primary results have not been published yet, but it does incorporate some novel methodology and is another way to illustrate how micro-randomized trials are being applied in the field of cardiovascular disease. And so I'll just talk here at a high level about the study design. So this is a study that's being led by Dr. Nalamothu and Dr. Dorsch here. But the MyBP My Life study is a prospective randomized controlled trial for patients with hypertension, and it recruited from 2 sites. It recruited from the University of Michigan Health here in Ann Arbor and from the Hamilton Community Health Network in Flint, Michigan. And what's really important to know is that for those of you who aren't aware, the Hamilton Community Health Network is a federally qualified health center in Flint, Michigan, and serves a predominantly Black population. Participants in the MyBP My Life study were randomized either to the control group or to the intervention group. And the intervention was a just-in-time adaptive intervention promoting increased physical activity, similar to the Valentine study, but also the selection of lower sodium food choices. And I'll show you in the coming slides what that looks like. Now, we completed enrollment of 602 participants in July of 2023, and participants are followed for 6 months for the primary outcome of change in blood pressure. And so we had follow-up from our last participant the last week of January. And so we are really excited to see the results of this study in the coming weeks. So one of the core aspects of the intervention was, again, these delivery of these push notifications promoting physical activity and lower sodium food choices. So physical activity interventions similar to Valentine were designed to disrupt sedentary behavior and to encourage low levels of physical activity on the order of bouts of 250 to 500 steps. So these notifications were tailored at a much greater number of factors than Valentine, and included things such as the time of day and day of week, the weather, but also the community and mobility. In contrast, dietary notifications were designed to encourage participants to select lower sodium food choices and included suggestions for lower sodium food choices to their commonly consumed or purchased foods, relying on the Nutritionix database. Notifications were tailored to the time of day, day of the week, community, and confidence in following lower sodium food choices. Now, importantly, both physical activity and diet notifications were tailored based on participants' communities, and participants received an admixture of community and expert-generated notifications. So one of the really unique aspects of this trial that the MyBP My Life study will be able to answer is whether having community congruent text messages improves their efficacy. So this was really great work that was led by Leslie Scalaris, who was here at the time and now is at Northwestern. But what Dr. Scalaris did is she worked with each of these communities to generate these messages and then to identify structurally differences between the messages. So to give you a flavor of what that looks like, at the first row here, a researcher expert generated message. This was somebody from our study team likely that wrote this. It's going to be a beautiful day. Started off with a walk. Check the app to see how many steps you got. This was the second. In the second column, you'll see a community generated notification, and this one was from the Flint community. So this says, ask the Lord to not only wake you up, but get you up and walking in the morning. And then finally on the right, the community generated notification. You're going to be, and this was from the University of Michigan community, you're going to be late, hurry up, you have to walk, you have to take your walk today. So you can see that there are differences between each of these three notifications. And one thing that Dr. Scalaris' team really identified was the theme of religiosity that arose in the Hamilton Community Health Network notifications. And so again, we'll be able to see the impact of community congruent notifications on their efficacy as we start to dig into these results. So here are a few screenshots from our mobile application. So participants interacted with a central visualization, which you can see on the left, or panel A. And on the left of that heart, you can see how many low sodium food choices they met relative to their self-selected goal and how their step count compared to a self-selected goal. They also had the ability in the subsequent panels, as you can see, to track their low sodium food choices relative to goals and step counts, review recent messages, and see how their blood pressure compared to AHA recommended target blood pressures. And so, again, I'm not going to go into the results here, but just to give you a flavor of what these interventions can look like. And hopefully in the coming months, you all will be hearing about the results of this trial from myself and others on the team. So turning now to the final section, I wanted to talk about some of the challenges that I see in mobile health technologies and mobile health research. And these are a little bit more general than just JEDIs and micro-randomized trials. So I've kind of broken these into three categories: design and delivery, interpretation, and implementation. So starting now with design and delivery, we really lack sufficiently granular behavioral health theories. And I think that can become really important when you're thinking about designing and delivering JEDIs and micro-randomized trials. The way that people interact with the intervention, the time scale, the frequency are clearly very different than with more traditional in-person studies. And so I think having more granular behavioral health theories to guide the design of these interventions is something that's going to be really important for the field moving forward. We also need greater methods, greater involvement of diverse stakeholders. And so certainly we need traditional stakeholders in the form of clinicians and patients, providers, caregivers. But certainly other stakeholders such as health information technology become really relevant here. And finally, we need more facile methods of evaluation. So micro-randomized trials are one example of an efficient means of evaluating our mobile health interventions, although there's been work in other experimental designs, as well as using real-world evidence and pragmatic trials to evaluate our interventions. And this is really important because unlike traditional drug trials, mobile health technologies evolve so quickly. And so relying on our more traditional means of evaluation would leave the technology antiquated at the time that the trial was complete. There are also challenges with respect to interpretation. So we lack longitudinal data collection in diverse populations. Many of you are familiar with the MyPact study that conducted here that enrolled participants, 7,000 Michigan medicine participants, and followed them for 3+ years. And this is one of the important gaps that MyPact is trying to address. But certainly many of our mobile health studies have been conducted over relatively short periods of time. And so understanding these longitudinal changes in mobile health parameters and informing prognostication is going to be very important. We also need device validation in diverse patient populations. I am a heart failure cardiologist, and so one of the things that is very challenging is that our wearable devices perform poorly in heart failure patients. They tend to perform poorly in patients with chronic conditions who have lower gait speeds. And so, again, understanding the performance of these devices within these different populations is important. And finally, we need correlation of digital endpoints with gold standards to facilitate interpretation. And I just wanted to highlight one study that we recently published that is trying to address this gap, although certainly much more work is needed. So this was a retrospective analysis that we did of the CHIEF-HF study, and we actually were privileged to be a top recruiting site for this study. But what CHIEF-HF did, for those of you who may not be familiar, is it enrolled patients with heart failure. Patients got randomized to receive a drug, canagliflozin or placebo, and then people were followed for 9 months. But during the first 12 weeks of the study, everybody wore a Fitbit. Actually, for the whole study, everybody wore a Fitbit, but the first 12 weeks of the study, everybody wore a Fitbit and answered KCCQ, Kansas City Cardiomyopathy questionnaires on their phones nearly weekly for those first 12 weeks of the study. And for those of you who are less familiar with the KCCQ, it is the gold standard for patient-reported outcomes in the field of heart failure. And KCCQ scores have been shown to correlate, to associate with a range of important heart failure markers and outcomes, including mortality and heart failure hospitalizations, amongst others. So the KCCQ is an incredibly well-validated endpoint in the field of heart failure. So again, in the CHIEF-HF study, they wore a Fitbit for 12 weeks and answered nearly weekly KCCQ scores on their phone. And we looked at the association between changes in step count from the Fitbit, as well as floors climbed, and changes in KCCQ scores. The idea was we really wanted to understand what is a significant change in step count and what is actionable. So we found that changes in daily step count were significantly associated with changes in KCCQ total symptom and physical limitation scores over 12 weeks. And importantly, we found a strong association for increases in step count and increases in KCCQ scores, but no association for decreases in step count and decreases in KCCQ scores. And while this was a non-linear relationship, we were able to quantify this. So for an example, a step count increase of 2,000 steps per day was associated with a 5.2-point increase in KCCQ total symptom scores. And the KCCQ score ranges from 0 to 100, and a clinically meaningful change in KCCQ score is thought to be anywhere from 3 to 5 points. So 2,000 step change was associated with a clinically meaningful change in KCCQ scores. And again, this certainly we need a lot more work, both in heart failure and in other cardiovascular conditions. But I just wanted to provide this example to highlight work that our group was doing to help provide a contextual framework for understanding this mobile device data. So finally, there are challenges in the field of implementation. So this includes access to and coverage of mobile health interventions. There has been increasing awareness of mobile health technologies as a super social determinant of health, and ensuring that there is access to this technology and understanding who will cover this technology going forward is an important question. There are also issues of workflow and data stream integration. Much of this work is being conducted in parallel systems. And so to develop sustainable interventions, I think will require that these be integrated into our existing electronic records. And I think it's really important that these workflow issues are addressed up front. I think this is really important for avoiding clinician burnout, but also ensuring that patients understand who is reviewing their data and at what cadence. I think some patients expect that their wearable device data is perhaps reviewed daily or weekly, and that may not be the case. And so I think level setting up front with both clinicians and patients as to the expectations is going to be important for developing a durable model. And finally, there are issues of enhanced privacy protections for users, although that is certainly a talk in and of itself. So turning now to just some closing points, mobile health technology is broadly defined and used and has the potential to collect vast amounts of data, both passively but also actively using ecological momentary assessments. Micro-randomized trials, or MRTs, are a novel experimental design, and these are used to guide the delivery of just-in-time adaptive interventions, JEDIs. And MRTs leverage with in-person contrast through sequential randomization and are thus a temporally and statistically efficient way of determining causal effects. And there are multiple real-world challenges to mobile device use in research and clinical practice. Also turning to a recent paper, a scientific statement out of JACC that Dr. Gambari just authored that talked about many of these challenges in more detail. So these are just a number of people, of which there are many more that have participated in this work. And importantly, a thank you to our study participants in the Valentine and the MyBP My Life studies. And with that, I am happy to take any questions.
Maybe I can start. Jesse, that was fantastic. I have a question about implementation. If you could maybe talk us a little bit through implementation and some challenges as far as payments are concerned. And if you could maybe comment on new testing strategies like ARPA-H and funding mechanisms that may be funding some of this work. And can you tell us if you're planning to kind of, test some of your interventions in the setting of an ARPA-H type of funding?
That's a great question. So I think from implementation, I think when I think about this work, I'm not sure that anything we've done has quite been ready to be implemented. I think that there's been a lot of fairly robust data that has shown that smartwatches in general work for, say, increasing physical activity levels. I think that that's out there. But whether kind of our interventions are incrementally increasing physical activity, I think is still like an unanswered question. And so I think we're a little bit upstream at this point in terms of kind of thinking about implementation. I, for one, am kind of trying to dive deeper into understanding kind of the behavioral health that guides some of this and using that to kind of work with micro-randomized trials to guide our interventions. So, and then to answer I have not dug deep into that funding mechanism, so I'm not sure that I can answer that question.
Yeah, I was just thinking of your blood pressure treatment interventions. That would be a good fit for that.
Yeah.
And the follow-up question I have is, can you comment a little bit on intervention fatigue and kind of approaches that you take to try to optimize engagement, and maybe comment on what is ideal engagement for intervention like you're instituting?
Yeah, that's a really great question. I think engagement can be defined in a number of different ways. And I think that there have been different definitions of engagement. Is it just participating and wearing um, wearing the smartwatch? Or probably not. It's probably more than that, and engaging with the intervention. One thing that the IBP My Life study is quantifying is actually interactions with the mobile application, how many clicks, how much time on each page, things like that, in terms of thinking about engagement. I think the more interesting question is, how do you improve engagement? And I think most of these JEDIs have shown kind of early engagement that you see typically in the first month, very similar to kind of what we saw, that often decrements over time. I think interestingly, we saw kind of a bimodal response, which is a little bit different and perhaps promising, but this kind of early engagement and then decrement is pretty typical of what you see in many health interventions, and JEDIs are not unique. Pedja Klasna, who's here in our School of Information, and Susan Murphy, who used to be here and now is at Harvard, is as you know, doing a lot of pioneering work in this field of engagement through reinforcement learning. And so we're looking forward to collaborating with them on some of our future studies and incorporating it into our future interventions. So the idea behind reinforcement learning is not that just you're looking kind of retrospectively to understand what types of notifications people respond to, but actually in real time for that individual person, you're understanding which types of notifications they're most likely to respond to, and in which context, and you're delivering those in a higher dose. And you're varying the overall dose of your notifications based on their response. So perhaps if you're finding that the response is decrementing over time, that maybe your algorithm is built in a way so that it actually kind of gives them a break from those notifications and then reintroduces them at a lower frequency. Dr. Klasna has recently gotten a number of grants, including an R01 that is actually focused on this idea of reinforcement learning and understanding that it's actually going to be in a cardiac rehabilitation population similar to Valentine. I think that will be really illustrative.
No more questions? Is step count, is activity really the best what digital biomarker for the types of interventions that you're instituting, or are there like other more interesting or more complex digital biomarkers that you could use?
Yeah, I think probably I think it depends on what your outcome is and what your intervention is designed to do. There's a really interesting study that just came out in Circulation last month. The Watchful study, I don't know if you saw that, but it was kind of similar to us, and it was designed to increase physical activity, and their overall goal was to actually improve functional capacity. And so their intervention actually increased step count without increasing functional capacity, which was their ultimate kind of goal. Which they assessed by a 6-minute walk distance. And so kind of their hypothesis was that like step count was actually, it was increasing their physical activity, but not at a high enough level to, lead to changes in functional capacity, which is what we really care about. I think step count may or may not be the right outcome depending on your population and what you would like your intervention to do. I think there are also potentially, more sophisticated markers that you can use and that we thought about. So, for example, for us, in trying to get these higher levels of physical activity and cardiac rehabilitation enrollees, at one point we tried to do time in their target heart rate zone, right? You're getting heart rate data from your smartwatch, and you could probably look at that. It ended up being more complicated than that. And I think physical activity through step count ended up being what was actionable. But I suspect that there probably are more interesting and probably better suited digital biomarkers.
Yeah, I ask you because oftentimes in clinical care, what I hear from patients is that what I was able to do, I can do less vigorously, or I'm not as quick doing things that I want to do. So to me, it seems like somehow, if you the speed at which you were performing your daily activities that you were previously doing seems like an interesting biomarker. Do you get raw 3D accelerometer data in your studies, or is it just mostly aggregate step count that you're getting?
Yeah, so we get so we do get, for Fitbit, we get like the intraday file. So it's more than just kind of the daily aggregate. We get kind of bout level physical activity, minute to minute heart rate, or every, 5 minutes, whatever the frequency is. So we do get the daily data. We don't quite get the, the raw accelerometer data. And so I think one thing that we have been thinking about a lot in our group is whether we should use a kind of third device, for example, like an actigraph, and give the same device right to everybody. Right, the first week of the study, the last week of their study, both your control and your intervention groups both get, the actigraph in addition to whatever smartwatch they're getting as part of the study. And I think that that's something that we probably do need to do in the future, right? So, one thing I didn't talk about and probably should have talked about was, right, we analyzed our Apple Watch and our Fitbit separately for the micro-randomized trial. And that's because there are measurement differences between the devices. Step count is measured by an Apple Watch is not the same as step count measured by a Fitbit. It's probably small, the differences, but you're comparing apples to oranges, or, maybe different like types of apples or something. And so we chose to measure them separately. And there are limitations to that. And so, we didn't do it at the time. In retrospect, I probably wish we had done it, but to give an actigraph accelerometer, and then we could have analyzed potentially, at least for those distal outcomes at baseline and 6 months, those groups using the same scale.
Yeah, it's super interesting. You can imagine looking at periods of rest within, if two people can have 2,000 steps that they've taken, but if they're taking breaks every 5 minutes or every 500 steps, for example, or the response of heart rate response to the same level of activity, yeah, really interesting work that can be done there. It's super interesting.
Yeah, and I think, to your point, you could think about things like chronotropic competence, for example, and how assessing, using kind of these more robust digital biomarkers than just putting somebody on a treadmill and assessing that. But we haven't gotten there yet.
Very interesting. Lots of interesting and novel things that can be done there.
It looks like we have a question in the Q&A from Catherine Barnier. And she asked, given that some participants mentioned that they would have valued a semi-competitive community, I'm curious to know whether any of the data you collected might allow you to learn anything about the potential influence of existing social communities on compliance. For example, are participants who typically walk with friends rather than walking alone more likely to follow suggestions from prompts? Alternatively, in the upcoming study you mentioned, in the cardiovascular rehabilitation setting, are there any plans to have a kind of control group that doesn't have the same social support to see if it influences compliance?
Yeah, that's a great question. So I'll get at that kind of from two different ways. So unfortunately, kind of the studies that we have going on aren't really allowing us to assess that question. It's more kind of an area for future research. We do have one study that is randomizing people to in-person versus telehealth cardiac rehabilitation. And in-person and telehealth cardiac rehabilitation are actually very similar, with kind of the exception being social support. Excuse me. And so one of our hypotheses is that if these two are not equivalent, then maybe social support is what factors into that. I do also have a K-23 grant that is looking at using those ecological momentary assessments, short questionnaires to understand when, with whom, and how patients with heart failure are physically active. And so we'll be asking them repeatedly over the course of multiple days, multiple weeks, who they are being physically active with to understand that social support. And we're going to be correlating their answers on those ecological momentary assessments with objectively measured physical activity. So some of our studies will start to kind of get at that question of social support, but unfortunately, the data we have right now is probably not going to answer that question.
Well, thank you so much, Jesse, for a fantastic talk. If you guys have any questions, you can either send it to us or email Jesse directly. And we look forward to hosting you again and hearing about the follow-up on all your studies. Thanks
That would be
again.
great. Yeah, thank you so much for having me, and thank you for being here today. I appreciate it.
Thank you so much.
Bye.